Hello everyone. Today we will talk about birth trauma. Although most babies in the world are delivered with few or no physical injuries, there is always a chance that something will go wrong during the birth process because each birth process is not predictable. And the average 29 out of every 1,000 babies all over the world suffer from the kind of a birth trauma, often as a result of poor use of instruments or improper handling of a newborn by doctors or other medical staff. Let's have a look what main issues and objects we will discuss today. And in present lecture, we'll talk about the incidence and causes of birth trauma, common birth-related traumas, early and late consequences of birth-related trauma, and the methods and the ways of prevention these injuries, because these injuries are really very serious and may lead to very serious consequences and complications as well in early childhood period or in the late life, even in the childhood or in the adult life, leading to different retardation in the physical or mental development. So, what is the birth trauma? Birth trauma is a term used to denote injury that is incurred by the delivered infant during the birthing process. Trauma at the time of birth is relatively low. As I told you, it's accounted about 29 out of every 1,000 born babies. And in total, it accounts for about 2% of all deliveries. Injuries to pregnant women that occur from trauma can be deadly to both mother and the fetus. In the United States alone, the leading cause of non-obstetric maternal death has been from trauma. Trauma can affect more births than actual birth trauma. Around 7% of all pregnancies may have been affected by a traumatic effect. And there are different many causes that may lead to birth trauma, and it may be affected the birth, both mother and the fetus during the birth process. And as I told you, birth process is unpredictable, and we can face with any urgent situations during this process. What are the main contributors to fetal death? These are, despite the fact that the pelvic fractures can lead to the fetal demise and injury, the most common cause of fetal mortality, secondary to trauma induced onto the mother, is placental abruption. One study calculated the rate of fetal death due to abruption was about 2.3 per 100,000 live births. Birth trauma is a general term. It's used to describe any cuts, fractures, or other injuries sustained by the newborn during the labor or delivery. Birth trauma is more common in developing nations, in Africa, Asia, and Latin America, but at least 2% of live births in the United States and the world are adversely affected by physical injuries not related to any of these cases. Birth trauma occurs more frequently among larger than the average babies, particularly in case when the baby size may be larger and it doesn't match the size and dimension of mother's pelvic area. And the causes for this may be quite different. It's maybe like anatomically contracted pelvis, or it may be obstetrically contracted pelvis when the size of the baby doesn't match the size or pelvic diameters. And in these cases, labor process is always obstructed. And if we will not prevent this condition, or we will lead to this abnormal process is going to go on, then we will face with different types of birth trauma in both mother and the fetus. And what is a birth injury? A birth injury is any type of injury that occurs during labor and delivery, and including trauma and oxygen deprivation. Birth injuries can range in severity from harmless to extremely severe, and many birth injuries result in permanent disability. Examples of birth injuries include intracranial hemorrhage, brain bleeds, cerebral palsy, seizures, and maybe different types of fractures, injuries of the soft tissues, of the visual organ, hydrocephalus, encephalitis, and many, many more types of traumas. And the most common birth injuries, according to the National Healthcare Quality Report, are 6 to 8 birth injuries for every 1,000 babies born. And among these injuries, there are some most common types. And these are cerebral palsy, shoulder dystocia, brachial plexus injury, and hypoxia of the fetus. What about the classification of birth injuries? And all these injuries classifies to the several groups. And these groups are damages of the soft tissues that include abrasions, erythema epithelial, ecchymosis, lacerations, subcutaneous fat necrosis. The injuries of the scalp, these are most common, especially in case of contracted pelvis and in breech presentation or brow and face presentations. And the most common skull fractures are caput succedaneum, cephalohematoma, subgallal hemorrhage, linear fracture, and intercranial hemorrhage. Fractures of the face or face injury, usually it's included the subconjunctival hemorrhage and retinal hemorrhage. Cranial nerve and spinal cord injuries. It includes facial palsy. Next group, it's a peripheral nerve injuries, and this group included brachial plexus palsy, unilateral vocal cord paralysis, radial nerve palsy, and lumbosacral plexus injury. The group of musculoskeletal injuries, clavicular fractures, fractures of long bones, sternocleidomastoidea injury, and the last group, it's intra-abdominal injuries that include hematoma of the liver, of the spleen, adrenal hemorrhage, and renal hemorrhage. As you see, there are various traumas that can occur during the birth process. Mechanical trauma related to birth usually occurs with pre-existing fetal-maternal risk factors. Several organ systems can be affected during the birth trauma. Neurologic, musculoskeletal, or visceral injuries can occur. Injuries can be mild and transient or disabling even life-threatening. Even these traumas may lead to fatal death. Imaging plays an important role in injury identification and triage of affected neonates. Generally, the most common neonatal injuries affect the baby's head, neck, and shoulders, although they can damage any other organs, and sometimes there are maybe different injuries at the same time. But for the developing of these injuries, there are some risk factors, maternal or fetal risk factors that are predisposing for the developing of these injuries. Let's have a look. What kind of risk factors may lead to birth injury? First of all, it's a fetal factor. It's a macrosomia, fetal macrosomia, when the weight of the baby exceeds 4,500 grams. Usually we observe macrosomic fetuses in the mother with diabetes mellitus. Malpresentation or shoulder dystocia is defined as passage of more than 60 between the delivery of the head and the body, resulting in requirement of additional obstetric maneuvers for delivery of the fetal shoulders. Maternal risk factors. It's a diabetes mellitus, because pregnant women with diabetes mellitus, they are in the greatest risk for the development of the macrosomic fetus, for developing of preeclampsia and fetoplacental insufficiency that may lead to the intrauterine hypoxia of the fetus, and labor abnormalities, usually as the obstructed labor or decreasing of the labor power. And all these factors may develop usually with high incidence in mothers with diabetes mellitus. Also, primiparity, contracted pelvis, and there are some obstetrics complication that may lead to the birth trauma. It's like epidural analgesia, induced or instrumental delivery, and induced or instrumental delivery, and it's also maybe the birth-related abnormalities or abnormalities that develop during the vaginal birth or the birth process. Hypoxia, it's the most common birth-related trauma, and hypoxia is a low level of oxygen, especially dangerous for the brain of a baby. Hypoxia can occur during the labor and during the delivery. Oxygen deprivation to the brain can result in a brain tissue damage. One of the biggest dangers of hypoxia is the development of cerebral palsy. Hypoxia, it's the most common birth injury, and hypoxia may be chronic or it may be acute. In case of chronic hypoxia, usually there is some complications of pregnancy. There are some complications of pregnancy or which are complications of the existing or pre-existing chronic extragenital disease, or complication that related with present pregnancy, such as preeclampsia or gestational diabetes mellitus, or maybe gestational hypertension or antiphospholipid syndrome. And these conditions that related to the present pregnancy, they may lead to the intrauterine hypoxia of the fetuses. Different infections, intrauterine infections, They will also lead to intrauterine hypoxia of the fetus. And one of the most common contributors to chronic hypoxia is the anemia of pregnant. Because as we know, pregnancy is the state with the highest demand of the iron, and when there is insufficient iron intake or poor nutrition during the pregnancy, and maybe the cause for that is a multiple pregnancy that follows by the increased demand in the iron, this condition will lead to the iron deficiency anemia. And pregnant women with iron deficiency anemia, they may develop chronic intrauterine hypoxia of the fetus. Also, we can observe acute hypoxia, and this acute hypoxia is related to the urgent complications of pregnancy, such as premature separation of the normal allocated placenta or placenta abruptia, or to placenta previa. And they associated with the acute blood restriction to the fetus and developing of hypoxia. Also, hypoxia, usually acute hypoxia may develop during the labor process. In case of obstructed labor or cord prolapse or prolonged labor or premature separation of the placenta during the labor process. Cerebral compression. Cerebral compression injuries can happen when excessive pressure on the baby's head causes a baby to have brain damage even without externally visible head trauma or low blood pH. In many cases, this is due to improper administration of pitocin or oxytocin, difficult, prolonged, or stalled labor, or a mismatch between the size of the baby's head and the maternal pelvis. Often, cerebral compression is benign, but excessive pressure on the baby's head can cause blood vessels to collapse, decreasing blood flow to the brain. Usually, cerebral compression we observe during the labor process in mothers with contracted pelvis. And both anatomically contracted pelvis or obstetrical or clinically contracted pelvis may be the cause for the cerebral compression. Cerebral compression may be transient when the degree of compression is not so significant, or it may lead to very, very serious traumas that even may lead to the retardation of physical and mental development in the future life. Here we can see head molding. It's a normal location of the skull bones, frontal bones, parietal bones, ear temporal bones, and occipital bone. We know that the bones of the vault, they are connected with each other with several sutures, and we distinguish sagittal suture between two parietal bones that extend from the posterior angle of the anterior fontanelle to the anterior angle of the small or posterior fontanelle. It's a larger suture of the vault. It's a coronal suture that connects frontal bones with parietal bone. It's lambdoid suture in the back area of the vault, and it connects parietal bones with occipital bone and the frontal suture that connect two frontal bones. And we have also two fontanelles, big fontanelle that have the rhombus shape and located anteriorly between two frontal and two parietal bones here. Also, we have posterior fontanelle that has the triangle shape and located between here, occipital bone and two parietal bones. It's located here. And what is the meaning of the sutures and fontanelles during the fetal period? It has a very great meaning because due to these sutures and fontanelles, the head of the baby molding. What is the molding? Molding, it's a physiological contraction of the fetal head with the decreasing of the head in its diameter that made it easy to pass through the birth canal. But sometimes when there is a compression, external compression, you can see deformity of the face in this picture, deformity of the vault of the head. And when the compression is excessive, it may lead to the very serious injury of the bones and the brain of the baby. Cephalohematoma. It's the most common type of birth injury, of the head injury. It's a superosseal collection of a blood between the skull and periosteum. It may be unilateral or bilateral and appears within hours of delivery as a soft fluctuant swelling on the side of the head. A cephalohematoma never extends beyond the edge of the bone. It crosses suture lines. And that means that cephalohematoma is local process and it's located over the exact bone and never spread and extend beyond the border of this exact bone. It is the swelling on infant skull in which collection of blood occurs between the pericranium and flat bones of skull. It is usually unilateral. Most of times it occurs over parietal bone. On this picture, we also see cephalohematoma over the parietal bone, and the predisposing factor for the developing of cephalohematoma, it's a process of compression, brain compression, precipitate labor, and the using of instrumental delivery, using of forceps or using of vacuum extractor. Here we can see the imagine of the cephalohematoma. We can see this is the skull, the bones of the skull. It's a parietal bone, and we can see the collection of the fluid over the parietal bone between the periosteum and the bone. Sometimes there can develop intracranial hemorrhages. What are the intracranial hemorrhage? We can distinguish subarachnoid hemorrhages. They attacks of secondary asphyxia or anapnoea and followed by the irregular breathing and bradycardia. Also, it may follow by the hyperesthesia, tremor, seizures, bulging of fontanella, sunset and grief symptoms as the positive. Also, they may follow by the changes of spinal fluid in lumbar puncture, and it becomes xanthochromic or contains blood. Also, along with the subarachnoid hemorrhages, we can observe intraventricular hemorrhage with the collection and hemorrhage inside the brain ventricles. the prevalence of an intracranial hemorrhage was estimated to be 26%. These hemorrhages were not associated with signs or overt trauma. The majority of these hemorrhages were found to be subdural and infratentorial. These were found to be without clinical consequences. Also, we can observe subgaleal hematoma. It's a bleeding in the potential space between the scalp periosteum and scalp gallia aponeurosis crosses suture lines. If the cephalohematoma, it's never extends through the sutures and is the local subgaleal hematoma, usually it's crossed the suture line and may extend on the large areas. And it's followed by the shock and pallor, also tachycardia, a low blood pressure. Within 30 minutes of the hemorrhage, the hemoglobin and packed cells volume start to fall rapidly because this hemorrhage increasing and it's continuing. Diffuse swelling of the head. Sutures usually are not palpable because of the extent of this hemorrhage through the borders of the sutures. The amount of blood under the scalp is far more than is estimated. Within 48 hours, the blood tracks between the fibers of the occipital and frontal muscles, causing bruising behind the ears, along the posterior hairline, and along the eyes. As you see, it's very serious damage and very serious trauma for the baby, and even this trauma may lead to the fetal mortality. Next group, it's injuries of the face. Most common injury of the face is the facial paralysis. Facial paralysis can be caused by pressure on the facial nerves during birth or by the use of forceps during the birth. And using of the forceps is the most common cause for the facial paralysis, especially in the wrong or incorrect administration of the forceps. And that's why we should be very, very careful as administrating of the forceps. The affected side of the face drops, and the infant is unable to close the eye tightly on the side or affection. When crying, the mouth is pulled across the normal side. Protection of the involved eye by application or artificial tears and tapping to prevent corneal injury, because baby cannot close these eyes sufficiently, and it may lead to the dryness of the conjunctiva and cornea. And it may be the sequence of the facial paralysis. And that's why we should use special drops that are very similar to tea drops and use these drops regularly. Neurosurgical repair is also one of the solutions of this problem, but this is the surgical operation and require the skills of the surgeon, because it requires the skills in the microsurgery because of the reparation of this nerve. And this nerve should be considered only after lack of resolution during the 1 year of observation. Also, we can observe ocular injuries. They are also common. They result from increased venous congestion and pressure during the delivery. Retinal hemorrhages usually resolve within 1 to 5 days. Subconjunctival hemorrhage reabsorb within 1 to 2 weeks. And sometimes they don't require any treatment. And in mild condition, they are just transient and resolve within several weeks. Retinal hemorrhages are seen among 1/4 of the otherwise normal deliveries, but instrumental delivery and cord around the neck have been identified as risk factors for the developing of these ocular or retinal injuries. Spontaneous vaginal delivery, prolonged second stage of labor, and neonatal intracranial hemorrhage can exacerbate these hemorrhages. In one prospective study, all detected birth-related traumal hemorrhages resolved by the 1 month of age. Coexisting of these hemorrhages with skull fractures or intracranial hemorrhage secondary to mechanical birth trauma can lead to confusion with non-accidental trauma. Other ocular injuries include the rupture of the cement membrane of the cornea, lid lacerations, hypema. What is the hypema? It's a collection of the blood in anterior chamber, vitreous hemorrhage, Purchase retinopathy, corneal edema, and corneal abrasion. Next group, it's an injury of the musculoskeletal system. And one of the most common injuries, it's a sternocleidomastoid injury, and it's impairment of musculosternocleidomastoidem. Sometimes it's associated with congenital muscular torticollis. It's atrophic muscle fiber surrounded by collagen and fibroblast and tearing the muscle fibers or fascial sheet with hematoma formation and subsequent fibrosis. The head is tilted toward the side of the lesion and rotated to the contralateral side. Chin is slightly elevated. If mass is present, it is firm, spindle-shaped, immobile, and located in the mid-portion of the sternocleidomastoid muscle without accompanying discoloration or any inflammation. That's why parents must be very careful and pay attention to the babies. Sometimes some parents, they didn't notice or pay attention to this tilted head or side rotated head, and they just consider as the normal, but they must be very careful because the early diagnosis of this pathological condition requires the early treatment, and we may get good results from this. As early we will start and diagnose any of these conditions, and as many benefits we may get in the treatment of these babies. Sternocleidomastoid hematomas can be seen with a dystotic birth. Alternatively, birth trauma-related venous ischemia of the sternocleidomastoid muscle has been postulated to result in benign fibroblastic proliferation or sternocleidomastoid muscle, also known as the fibromatosis colli. Sometimes it's a birth-related trauma, but sometimes there are predisposing factors as congenital injuries or congenital pathology of this muscle, usually unilateral with a right-sided predilection. This entity manifests between the first 4 to 8 weeks of life as a neck mass or torticollis. Ultrasound is the imaging study of choice and demonstrates fusiform enlargement and heterogeneous echogenicity of the affected of muscle, which may appear mass-like. Results in torticollis. It occurs during delivery of anterior shoulder in a vertex presentation or while rotating shoulder in a bridge presentation. And usually these are birth-related traumas, and they carry just iatrogenic character. Here, the ultrasound presentation of fibromatosis coli, and we can see it like a fibrosis mass in the area of this sternocleidomastoid muscle. Brachial plexus injury, it's also one of the most common types of injury. Usually we observe this type of injury in the babies from the mother with contracted pelvis or macrosomic fetuses in case of obstetrically contracted pelvis. Usually one of the most common types of this brachial plexus injury is Erbs-Duchenne palsy, and it's associated with the injury of the C5 and C6 afferent nerves. It's the most common injury, and followed by the lack of the shoulder motion. The involved extremity lies adducted, prone, and internally rotated, as we see in this picture. You can see this hand of the baby. It lies adducted and it has internal rotation. Moro, biceps, and radial reflexes are absent on the affected side. Grasp reflex is usually presented. These are the differential diagnoses for the Erbs-Duchenne palsy. Erbs palsy may be associated with injury to the phrenic nerve innervated with the fibers from the C3 to C5. Here, we can see on this picture, and we can see 5, 6, 7 nerves, and usually the damage of these nerves may lead to the Erbs-Duchenne palsy. And it's also very serious complication and serious trauma, and brachial plexus injuries can occur prepartum or intrapartum. Incidence of obstetric brachial plexus palsy has been estimated about 1 to 1.5 per 1,000 live births in the United States. Unfortunately, we have no such data from our country. The commonest fetal risk factor is macrosomia. And macrosomic fetuses usually develops in mothers with diabetes mellitus. However, any maternal fetal conditions predisposing to fetal trauma, including maternal obesity, maternal diabetes, or instrumental delivery, can be implicated. One of the other common causes for this brachial plexus injury, it's abnormal rotation, it's external cephalic version or combined internal external cephalic version, and also administration of the forceps. And these methods may lead to the development of the brachial plexus injury. Clavicular fractures often coexist with brachial plexus injuries, and we observe these conditions at shoulder dystocia. Caesarean can be protective, but does not exclude the likelihood of a brachial plexus injury. And we consider here the injuries that may develop during the pregnancy, not during the vaginal birth. Here again, we can see, you can see this is damaged hand, and we can see the nerves that derive from the spinal cord in the neck area, and they goes to the upper extremities for the innervation, and usually the damage happens in this area. Spinal cord injuries are rare conditions which may occur in contexts of difficult delivery characterized by excess traction, rotation, and hyperextension. Breech presentation complicated by entrapped fetal head has been found to be responsible for many reported cases of spinal cord injuries. Vertebral fractures or spinal dislocations can be associated. A lateral radiograph of the spine should be obtained to demonstrate vertebral fracture or subluxation. The neonate can present with hypotonia, quadriplegia or paraplegia. Plain radiographs, ultrasounds, and MRI can be helpful, beneficial in the diagnosis of these injuries. We can see the spinal cord and the injuries of the spinal cord, because spinal cord, we know from the anatomy that it's very, very important because nerves that innervates all our body take the beginning in the spinal cord, and any damage of the spinal cord depending on the area of the injury may lead to very serious complications of the part of the body below the area of impairment. Clinical findings. It's decreased or absent of spontaneous movement, absence of deep tendon reflexes, absence of periodic breathing, lack of response to painful stimuli below the level of the lesions. Lesions above the C4 are almost always associated with apnoea, and this means the damaging of the breath center, and it will lead to the abnormal breathing. Lesions between C4 and T4 may have respiratory distress because it involves cervical and thoracal area and innervation of the organs that locates in these areas. And this respiratory distress usually is secondary to varying degrees of involvement of the phrenic nerve and innervation of the intercostal muscles. One of the most common injuries is also clavicular fractures. We'll talk about that because clavicular fracture we may observe in shoulder dystocia, macrosomic fetuses, and the obstructed labor. Clavicular fracture, it can occur with dystotic birth or with forceps delivery. Incidence of clavicular fracture, it's about 2.7, 5.7 on 1,000 live births. They can coexist with humeral fractures, traumatic brachial plexopathy, and injuries to the phrenic and recurrent laryngeal nerve, and its association of the different injuries, and this complex amount of these injuries may have very, very serious consequences and may lead to the very serious disability of the baby. Beside the clavicule, fractures of other flat bones such as ribs, mandibula, and spine have also been described in the literature. It's a complex, several injuries that are the consequences of abnormal birth process. The group of the injuries of soft tissues. Usually one of the common injuries is subcutaneous fat necrosis, and it's followed by the irregular, hard, non-pitting subcutaneous induration with overlying dusky red-purple discoloration of the extremities, face, trunk, or buttocks, and may be caused by the pressure during the delivery. We can see redness and the coloration or hyperemia of the skin over the affected area. And usually it doesn't require treatment. And the treatment is also administered if it's necessary. Sometimes this subcutaneous fat necrosis calcifies and may lead to the development of these very firm nodes under the skin. Conclusion: mechanical trauma related to birth can affect different organ systems of neonate, while often of little clinical consequences. Traumatic events can lead to cosmetic deformity, functional impairment, and, in extreme circumstances, even may lead to the fetal or neonate death. And that's why it's very, very important to find out all the possible complications, to find out them timely to prevent the very serious birth trauma that may occur during the birth process. And this will dramatically decrease the rate of the neonatal morbidity and neonatal mortality. Also, it will lead to the decreasing of the amount of peoples with a congenital trauma or birth-related disability. And of course, the main role plays timely diagnosis and prevention of these conditions. And at the end of our lecture, I want to tell you the quote of Buddha. Every experience, no matter how bad it seems, holds within it a blessing of some kind. The goal is to find it. And on this positive note, I want to finish my lecture. Thank you for your attention.